So Eric, maybe in the last part of this section, just mention about resistance. Are we seeing resistance? You know, you talked about barrier to resistance with different drugs, but kind of resistance emergence altogether.
Yeah, so it's, you know, so we have in our clinics, we have two populations. We have those people like Dan was talking about who started with sequential monotherapy or dual therapy who've accumulated a lot of resistance. Most of those people who are still with us now became suppressed when, you know, darunavir came out and integrase inhibitors came out. Those starting therapy for the first time, resistance is very rare, even in the clinical trials, right? We talk about boosted PIs, no PI resistance, dolutegravir-based regimens, no integrase or nuke resistance. But when we point fingers at other drugs like elvitegravir and raltegravir, saying resistance does develop with them, but it's, you know, in 3 people.
Right.
So it's, I think in clinical practice, as we get better and better at selecting our patients for treatment, supporting them during treatment, that true virologic resistance is really quite rare. We still have to look for it.
Sure.
And occasionally we send a resistance test, but I have to admit, it's occasionally, even in a big clinic. We rarely have to do it.
Yeah, this idea, Dan, you started out our whole conversation with the biology of how really to select for new resistance, you have to have ongoing replication. And part of the reason we're so focused on viral loads less than 50, 40, 20 is that reason, right? I mean, it's not because we're obsessed with numbers, but
Oh, exactly. So, you know,
the
way the virus replicates, it's a really sloppy machine, and it makes lots of mistakes. And so if you let it make mistakes, some of those mistakes inevitably will be ones that generate a resistance mutation, and the drug will become less and less effective. And if you use enough drugs, it takes too many mistakes for them to occur by chance, and you prevent that from happening, and then you can get really, and I think the data are now really compelling that somebody whose virus load is below the threshold of detection by any of the commercial assays, for all intents and purposes, has no ongoing virus replication and therefore will not get resistant. There really isn't the phenomenon of the person sort of breaking through late after 3 or 4 years because they've now developed resistance when they were always taking their medication and there was no replication. If you probe deeply enough, it's always because somebody took a drug holiday, they were unable to continue to get their drug, they ran out of drug, they got incarcerated and couldn't get hold of drug, a variety of different reasons that lead to virologic failure with or without resistance. It's not because magically resistance emerged. So luckily we don't have to worry about it, and with the newer regimens we don't even worry so much about transmitted resistance anymore.
Right.
So the need to do a resistance test before starting someone on treatment, although still officially in the guidelines, even as a former resistance investigator, there's not much to investigate.
You're recovering resistance investigator.
You know, there's really less and less rationale to be doing resistance testing before starting someone on therapy.